Talking about scaling, if we want to scale the kind of work that Dr. McKee's talking about, we need an army. At the moment, integrative medicine, I think, is like a rabble, right? We're all doing our own thing, and we're all passionate about it, but we're sort of a rabble. What we're trying to do here at the Evolution of Medicine, and what Nalini's trying to do, is get everyone organized in a way that we can really have an impact on population health. And so, one of the things that you'll see this year is that we're going to feature practitioners who have scalable training courses to be able to train people in integrative oncology, integrative psychiatry, integrative cardiology, because we need these scalable systems to build and organize this army. So it's my great pleasure to welcome to the stage for her debut on the Functional Forum a doctor that I think I've known for maybe longer than any other. The first time I did an event on the West Coast. It was called Integrative Medicine and Social Media, The Future of Medicine is Now. It was almost exactly 6 years ago. It was January 2011. Nalini was there. She's been on the cutting edge and being since then, I think, creating this, which is a way to get thousands and thousands and thousands of practitioners to practice optimal integrative oncology. Please welcome Dr. Nalini Chilkov.
Like disco fever is like part of this. So what if every cancer patient had not only a plan for their disease with their disease expert, the oncologist, but they had a plan for their health also from the very first time they had their diagnosis? And what if every patient was told by their oncologist, we're going to take our time, you're an N of 1, and we're going to make sure you have exactly the right individualized program for you so that your endpoint is health. But health is not part of the lexicon in oncology. What if from the moment that a person was diagnosed, instead of feeling like their hair just got caught on fire, they were told, before you start the challenging treatments we're going to recommend for you, we want you to meet with a health expert so that you feel that you have control over what's happening to you. We want you to know how to stay healthy while you go through this, but most of all, we want you to have health as your endpoint. That's not the framework in oncology, but we can bring that to the oncology patient and to oncology groups. And so I want to show you how to think about that, because there is a shortage of oncologists, and there's going to be a shortage of internists as well. And we have the framework and the tools to deliver this health to cancer patients. The need is incredibly huge. 1 in 2 men, 1 in 3 women in the United States today are going to be diagnosed with cancer in their lifetime. In addition to that, by the year 2024, which is not so far away, there will be 19 million cancer survivors in the United States alone. And these curves are similar for Europe and Canada, and where we have modernity. In places where people don't have access to health care, we really don't know. But what is really poignant here is the number of people who are cancer survivors who have no one helping them to stay healthy. And this is where we can come in. And it's often when patients come in the door. It's also true that if you didn't specialize in oncology, you don't know how to take care of these patients. You don't know what cancer patients need to make it through chemo and surgery and radiotherapy and hormonal therapies. And you don't know what to tell a patient after they've had successful therapy to really keep them from having a recurrence. So let's look at what we can do to become confident and educated to take care of the patients who are actually already in our practices, who have these risks and have these histories, but they don't know we can help them. So this is a framework for how I think about the cancer journey, because each stage has its unique needs. And it's also useful for the patient because anxiety makes you think, what if, and go into the future. So I tell the patient, you're in this stage right now, and this is what you need to do now. And when we get to the next stage, we'll take care of you there also. When a person is just diagnosed is when I really want them to come in to my office. And if we have oncologists that think that's a good idea, then we will. This is an opportunity to give the patient a sense of agency and control, and to communicate to them that cancer is not an urgent care diagnosis, it's not an emergency diagnosis, it's a project. And we should be thoughtful about it, of how we're going to go about it. What can we do for patients? We can transform their outcomes and their prognosis. This is probably one of our most powerful things because we have a health model. We can enhance oncology treatments. Sometimes patients will actually not be able to make it through their good treatments because of toxicities or because the treatment doesn't really cover all the bases, but we could fill in those gaps. One of the strongest things we can do is when people are in treatment, they often come in the door then when they start to have adverse effects. And we can help them to manage the short-term, but even more important, the long-term adverse effects of cancer and cancer treatments. Over 40% of cancer survivors complain of fatigue from 10 years ago treatment, and no one is helping them. I had a patient who came in with severe neuropathies from successful breast cancer treatment, which she had had for 8 years. She was in so much pain that she had decided to euthanize herself. She was a high-functioning music industry executive who had had it. And someone said, well, why don't you talk to Nalini first? So within 10 weeks, we solved her redox recycling problem, and we gave her nutrients that rebuild nerve and nerve sheath. In 10 weeks, we healed her nerves. And that was over 5 years ago. She's very much alive and wanted to put me in her will. Okay, let me actually finish this here. We want to be the ones that provide the health model. So in treatment is when many people come in the door if they know you're a resource, but they might not know that you can be. After treatment is also when many people seek care because they might feel in conflict with their oncologist or have a closed-minded oncologist who will not collaborate. But I will tell you, if you pick up the phone and talk to the oncologist, let them know you're going to do the health side of the equation, they can do the disease side of the equation, they don't feel like you're stepping on their toes, and you can then build relationships. For 30 years I've been doing that. I've been picking up the phone, making relationships with radiologists, medical oncologists, and surgeons. And when they see that patients do better, they're happy to refer. They're happy to hear that a patient is having this kind of support. Then we want most of our patients to be the outliers who have life beyond cancer, and their life no longer is about cancer or being a cancer patient. But there's a huge population of people that need us desperately, and that is the population of patients living with cancer as a chronic illness. These are patients that may have had a recurrence, a second recurrence, a third recurrence. These are patients who maybe had conventional treatment that didn't solve the whole problem. And so these patients might be undergoing ongoing toxic therapies to control the cancer, and they need our help to stay healthy for this long-term exposure to toxic drugs. Now, the tumor microenvironment is where we want to put our emphasis. And the way I describe it to patients is think about the soil in a garden. If that soil is nourishing the plants, then we have healthy plants. But we might have weeds if we have very poor soil. And we think of cancer cells as the weeds. And one of the most wonderful integrative oncologists in our community is Don Abrams at UC San Francisco. And this is what he says. Modern Western oncologists focus on destroying the weed, while integrative oncology concentrates on the soil the weed grows in and on making the soil as inhospitable as possible to the growth and spread of the weed. And that is our job. So we want to focus on the tumor microenvironment because that's where we can have the biggest impact. So I'm going to show you how to do that with a framework that will allow you to stick your toe in the water and get more comfortable working with these patients so that we can build an army of our community that becomes a resource to the oncology community wherever you practice. So our job is to create a body where cancer cannot thrive, an environment physiologically that is not hospitable to carcinogenesis, the development of cancer in the first place, to proliferation, to progression, and to metastasis. We want to put the brakes on all of that. So we need a plan to fight the tumor. When a person is diagnosed, you want to reduce their tumor burden. That's your first job. You have to figure out how to do it. But simultaneously, we want to nourish the patient. And if we have an oncology group that will talk to us and humor us, then you stick your toe in the water, do things that won't interfere at all, and let the oncologist see the patient do better.